Good afternoon. My name is Ann Greiner, and I am President and CEO of the Primary Care Collaborative. And I wanted to welcome you to this afternoon's webinar focused on Medicare ACOs in primary care and what ACO leaders have learned. I think you're really going to enjoy this conversation. We have ACO leaders from across the country that are practicing, are leading organizations in very different geographic areas with different patient populations and different workforces. I think we're going to learn from them what are the ingredients to ACO success and how primary care contributes to that success. For those who may not know the Primary Care Collaborative, we are a nonprofit, multi-stakeholder membership organization that focuses on strengthening primary care as the foundation of all high-performing health systems, whether in this country or across the world. This particular webinar is part of the Primary Care Collaborative's Better Health Now campaign, which was launched at the end of March. That campaign focuses on moving the recommendations in the recently released National Academy Science, Engineering, and Medicine report, the payment recommendations, into policy. And we believe that if we are able to advance payment reform, pay primary care differently, invest more in primary care, which is what the NASM report calls for, we'll be able to transform primary care, and all primary care practices will be able to deliver the kind of primary care that advances population health in dramatic ways, closes equity gaps, and also helps to reduce costs in the long run. Now I'd like to introduce our moderator for today's conversation. And I'm very happy to welcome Linda Brady from the Boeing Company. For those of you who may not know Boeing, and I'm sure that you do, they're the largest aerospace company and leading manufacturer of commercial jetliners, defense, space, and security systems. Linda is a member of Boeing's Healthcare and Wellbeing Strategy team, and she manages its provider network and healthcare analytics strategy. In her role, she manages the overall portfolio of Boeing's value-based care direct contracting initiatives, from initial design concept through contract development, implementation, and sustaining those changes. She has over 20 years of experience in the healthcare industry, and she's a Six Sigma Green Belt. Wow. Prior to Boeing, Linda was a consultant at two leading health benefit consulting firms, where she advised large, complex organizations on their health benefits strategy. Linda, let me turn the mic over to you, and I'm really looking forward to our conversation today.
Terrific. Thanks so much, Ann, and thanks for including me in this really important conversation. So before I get started, I'm just going to go through a few housekeeping reminders. First, all lines are automatically muted. And so we're going to take questions from the audience in the last several minutes of the webinar. Then you can submit your questions at any time via the question box. The webinar is being recorded, and this recording and the slides will be posted within 24 hours of the webinar. So let me just provide some context for what we're about to talk about and who we're going to hear from. So as you know, the Medicare Shared Savings Program, also known as MSSP, is the largest Medicare ACO program and was established in the Affordable Care Act in 2010. The program, however, has not been static. The CMS has made changes in terms of participants over the 10 years of its existence. Practices and ACOs, they've formed, they've joined, they've dropped out, they've delayed, they've sort of evolved with as they learn as they go, and that have delayed participation in the program. All of the participants in the program, it is voluntary. So in May, the Primary Care Collaborative looked at the research literature about the program. So this month, today, we're going to focus on hearing from those ACO leaders and what they've learned and what they've discovered over the years as they've been driving this change at the health system or ACO level. So today we've got three experts who are going to be participating in the conversation. Let me introduce them to you, and then they're each going to talk a little bit about their leadership roles and how they've been supporting ACO practices and what they've learned. Before I introduce these panelists, just a quick note of background to reinforce some of the things that Ann shared. So one of my roles at Boeing is to oversee our direct contracting. We have ACO relationships in 5 markets. So we've been doing this for, this is our 8th year doing this, following similar patterns to what was set out by the MSSP program, but adapting to what we need to do for a commercial population. And it's to say it's been a profound, almost decade of learning would be an understatement. So I am particularly interested in hearing directly from these ACO leaders and their perspective on where this is going. And I will add our deep interest in the role that belief that the role that primary care plays in terms of changing, truly changing the game as we look ahead. So our panelists today, I'm going to start with Dr. Sarah Mullins. Sarah is the Senior Regional Medical Director for Aledade, their ACO organization. She oversees clinical engagement in the Northeast region and personally coaches physicians in Delaware, also in Maryland and Washington, D.C. The Adelaide ACOs include more than 1,000 independent practices and federally qualified health centers. And they engage in 98 Medicare contracts and 47 other value-based care partnerships. Dr. Mullins is a practicing family physician and owner of Stony Batter Family Medicine in Wilmington, Delaware. Her practice has partnered with Aledade since 2014, and participants in value-based contracts through Aledade for Medicaid, commercial insurance, Medicare, and Medicare Advantage. Dr. Mullins received her Bachelor of Science in Marine Biology from Duke University and her medical degree from the University of Maryland Medical School. She served as Chief Resident for the Christian Care Family Medicine Residency in Wilmington, Delaware. The next panelist that we'll be hearing from is Dr. Fred Wallisch. Fred is with Caravan Health. He's Caravan Health's Medical Director of ACO programs. In this role, he is responsible for clinical oversight of all ACO activities, including collaboration with physician leadership on data-driven, value-based care strategies to improve patient outcomes, quality of care, utilization metrics, all to drive client success. He leads the clinical implementation of new and innovative strategies across all of Caravan's ACOs. Dr. Walsh provides clinical leadership for all physicians, clinical expertise, and business direction in support of medical care management programs through participation in clinical team activities, policy development, and program performance monitoring. Dr. Walsh is board certified in family medicine with a passion for improving the quality of patient care with an emphasis on proactive and preventive care models. He brings over 20 years of practice experience and 8 years of medical management to this role, including generating significant shared savings in the Medicare ACO programs. Dr. Walsh received his Bachelor of Science degree in chemistry from Rockhurst College in Kansas City and his medical degree from the University of Kansas Medical Center. He completed his family medicine residency at Deaconess Health System in Evansville, Indiana. And then our final panelist is Dr. Jose Pena. Dr. Pena is the Chief Executive Officer and Chief Medical Director of the Rio Grande Valley Accountable Care Organization of Health Providers. His primary areas of focus include process improvement and innovations in patient-centered diabetes management. His organization has become one of the most successful ACOs as measured by both quality metrics and cost savings. Prior to working with the Rio Grande Valley Accountable Care Organization, Dr. Pena served in a variety of leadership roles in local hospitals. He is board certified in internal medicine, hospice, and palliative medicine. And Dr. Pena completed his postgraduate training in internal medicine at St. Barnabas Hospital in New York. So welcome to all the panelists. And I'm going to turn first to Dr. Mullins, who's going to give an additional background into her experience and the work she's doing with Aledade. Dr. Mullins, over to you.
Thank you. So working with Aledade has been an amazing 8-year experience. I joined as a partner, as practice number 7 in Aledade out of those 1,000+ practices. And I have to say, I've watched the company grown from Washington to Florida and all the way in between. And I think really the thing that was very interesting to me was that This is a national movement for people who needed a national movement, those independent physicians. So whether they're practicing in a rural health center, a federally qualified health center, an independent owned private practice, this was a group that was kind of left to the sidelines when it came to policy making and to really having advocacy in their favor. With 98 different Medicare contracts, there's absolutely been a force to work with these practices in the way that suits them best. And as you can imagine, with the geographic differences, the practice sizes, the demographic differences, we had to come up with a simple structure that would work for everyone. To address patients with all different types of needs, there had to be a structure that really focused on preventative health, transitions from out of the emergency room and the hospital, and really truly leveraging that relationship between the primary care and their patient in order to get the best outcomes for patients. I think when I look back to 2013, when my practice was prior to the value-based movement, and we have come such a long way in those 8 years for delivering population health in a sophisticated way. I like to think of what it used to be like around here, and to say it was discoordinated is kind of what I imagine a lot of practices look like prior to having this type of transformation. Data being delivered at the point of care is so critical, but also the coaching. So the clinical coaching coming both from the physician leadership, but also from the practice transformation reps that help with the practice management to facilitate team-based care is really what makes these differences drive forward. Next slide. We'll take a look at these results for the Medicare Shared Savings Program in 2020 at the top of the chart. And you can see that $93 million paid to practices. On average, a solo practice would receive $198,000. This is the kind of money that does transform care. It does provide for people to be able to hire care managers and start care management programs and really be able to make differences in the practice around health equity that possibly didn't have bandwidth before. When I look at the community doctors around me, I can count practices that have closed around me. And that's really the kind of care I keep talking about in the advocacy arm to our legislature. There's gonna be no one left here to deliver the care you're imagining if we don't secure the future for practices on boots on the ground. That's really what we need. Now, with our federally qualified health centers, some of the biggest priority has been our Medicaid patients. And I think not forgetting that when practices serve a diverse group of people, we can't just focus on our Medicare patients only. The value-based movement has to be for all patients. I am excited that 90% of my patients are engaged in a value-based contract in my practice. And that allows me, when I see patients, to treat every patient the same and not leave anybody behind. I love the idea that we have been working on the curriculum for practices that are in their very first entry into value-based medicine and continue to engage our practices that have been doing this for a decade. That's really where I think we can move the most, and having that ability to work on primary care reform and advocacy along the legislature with policy reform just expedites this process. Thank you, Linda.
Thank you, Dr. Mullins. Dr. Pena, do you want to go next?
Sure, and thank you, Linda, and thank you for the Primary Care Collaborative for the invitation to this panel. Our ACO is called Rio Grande Valley Accountable Care Organization, and many of the people in the audience might remember the name McAllen, Texas, as a high cost, the second highest cost area back on 2009, 2010. And we jumped to this ACO movement when it was published, the final rule 2011. When we started in 2012, we decided to take downside risk because we think that keeps us focused and can be done by a small group of primary care. So we discovered why this area was in high expenditure, because there was too many home health and duplication of testing. So we tackled those issues. We developed our internal group of nurses, care coordinators, and we were able to go slowly decreasing the cost of care and improving the quality. We have about 55% of diabetes in our area because it's the Mexican-American population. We were able to go in A1C above 9 from 26%, 25% to less than 7%. That is, it put us in the top 1% in the country with that effort. And, you know, our population is challenged, but lessons learned is it can be done with a group of focus administrators and physicians, learning, outpacing case management and outpacing intensive care. It can be done. So we have about 20,000 live on Blue Cross Blue Shield, about 10,000 with Medicaid, and about 10,000 with Medicare. Now we are excited going to ACO Reach. We are waiting the answer from CMS this week. That program is gonna help us more to reach, as the name said, people that are on disadvantage. We are developing a very aggressive home visitation program, transition of care following the GRACE model from the University of Indiana. So we are very excited. We're seeing a lot of progress has been done, and the Rio Grande Valley is not one of the most costly on the country anymore. And the outcome is very good thanks to 4 ACOs and 2 Medicare Advantage plan. So every year we have been doing very well on high quality and decreasing the cost of care. Next. Every one of those little boxes is a conference apart. So it's like 17 hours to explain, but this is the ABC on cost reduction that together with equality. We think that the program need to deliver savings in order to hire people, to hire the social workers, hire the care coordinators, our team of nurses, and the whole, again, the nurse practitioner that do the home visit. So it's some program focused on the quality only, but we think I need to do both. You need to work on the increasing the quality and decreasing the cost of care. So we do a lot and very intense and very focused. Again, as he said there, with our data driving, we create our own IT infrastructure. So we work with some of the local hospital on a health exchange. So we get report daily from the hospital, people that touch the emergency room that had been admitted, because the report from CMS take too long. So we are testing now behavioral health integration, bringing mental health professional directly to the PCP office. You know, and I can keep talking for hours, but I was advised only 4 minutes. So you can read those. We'll stop right here and just ask me any question that I can help with. So thank you.
Thank you. Thank you, Dr. Pena. And I think all of us would agree we could talk for hours on this. Dr. Wallisch, you're turning to you for your introduction.
Sure. Thanks, Linda. And thanks the Primary Care Collaborative for the invitation. So I'm a medical director at Caravan Health. We are now part of Signify Health, and I'll talk about that in just a second. But Caravan has been around about 8 years and really was born out of the rural health space. And you know, the initial MSSP programs that came out, you know, really required some numbers and some size in order to make sense. And born out of that necessity, the founders of Caravan really looked across the country and were able to grow with our rural health and small community partners who may not have been able to move into the value-based space without coming together. So Caravan is the largest convener of rural health and small community hospitals into ACOs. About 150 employees. We represent over 22,000 clinicians, 300 health systems, about 600,000 covered lives within the Medicare Shared Savings Program, and represent 6 ACOs currently. You know, if you look back over the history, that's been a number that has ebbed and flowed throughout time, but there are currently 6 ACOs within the MSSP of all you know, all the different levels of participation there and risk levels. And our ACOs range in size from about 5,000 to 260,000 attributed lives. You can see we're well representative across the country with focuses in small to rural sized communities. Go ahead to the next slide. And you know, the success Caravan has had really is a testament to the vision of the founders who were able to recognize within those rural spaces the quality care that was taking place predominantly through primary care, and able to leverage that success and teach really the foundations of value-based care to groups that were doing it but maybe didn't recognize that they were doing it. You know, across since 2015, saving the Medicare fund over $510 million through our ACOs in 2020, and anticipated in 2021. 100% of our participants will receive shared savings. Nobody's in the business of paying CMS back, so we're proud of the fact that we've been able to maintain that success with very high 90% quality ratings. Currently, you know, we are in transition as Signify acquired Caravan a couple months ago. Signify is the largest convener of bundled payments and has significant contracting strength with specialty, with post-acute care, and with payers throughout the country. So we think this is a great relationship, and really looking forward to taking that relationship to the next level. You know, bringing the experience of Caravan in the ACO space and Signify together to do great things as we move forward. So looking forward to this conversation today.
So thank you all for taking the time to walk us through your stories and your incredible success actually in looking at this. I think the Primary Care Collaborative did an evidence-based report in 2018 that sort of tried to isolate the top reasons how or why an ACO will succeed. And among those was the leadership and the culture, and also physician, I would describe as sort of physician behavior and practices. I think the last 2 years going through the pandemic certainly made it obvious that the way we go about doing primary care is not sustainable. We saw a lot of primary care practices buckle under the pressure and the response by the community to move quickly to more what I would call spot-on support like telehealth and the such. I'd like you to talk a little bit about why that isn't also a sustainable solution. Why, what role primary care is going to play in terms of building that sustainable health system that's affordable, that actually drives and impacts outcomes and health. So can each of you just take a few minutes to talk about how you're working with your primary care clinicians on how they're going about building those relationships and convincing people to come into your practices? Dr. Mullins, we want to start with you?
Sure. I think one of the things we experienced in our practices across the country during the pandemic was that patients were so grateful to hear from their medical home. And this was not evidenced by them feeling allegiance to the local emergency room. Certainly we saw those emergency rooms go dark and go vacant for the patients who could avoid it. But as the outreach calls started out of practices, as telehealth started up in practices virtually overnight, we saw our practices see parking lot visits, car side visits became part of the norm in all weather, and the phone calls to the houses in order to make sure that people had their medicine, that they weren't going without primary care, I think really speaks more to the relationships that had been built over decades and the trust in the location in the primary care setting. Finally, I'd just like to say that we're a great deal. And I say that to my patients all the time. I'm a great bargain compared to any other place that you'll get healthcare. I am one of the best as far as cost effectiveness. So I think that's something that really will stand out for primary care for years to come, is that we're still a great deal.
Thank you. Dr. Pena?
Yeah, regarding COVID was life-changing. I mean, it tests us our ability to do some sort of rapid response in the primary care setting. You know, we didn't lose any time giving away a bunch of masks before the vaccines and using the telemedicine from 0 to 80% and so on. Providing oxygen concentrator to those patients that don't want to go to the hospital, and everything that has been on our hands. The legacy has been the telemedicine, so now it's customary for us to see a patient and get to do a short, quick assessment, you know, 1 week later by phone to make sure that, you know, patients are taking the medication the right way, blood sugar coming down, blood pressure coming down, and so on. So it has made us more agile, if you will. Then the patients also have been more educated that they regarding relationship with PCPs, that we can solve pretty much 80–90% of the problems. Doesn't need to see a cardiologist for a blood pressure control. We have shown diabetes with all the respect that our numbers are better than the endocrinologist, because we have a secret weapon, and it's called care coordinator, that they don't have. So, and our relationship with the hospital, you know, some of them are not happy because we have decreased admissions and readmission by 15% or so. But we told them we are sending more bariatric surgery and less cabbage and so on. So we feel good about what we has been done in the last 10 years, and, you know, ready to embrace the future through the ACO reach. Optimistic more than ever.
Dr. Wallisch?
I'd like to echo what's been said, that relationship is critical. I don't practice anymore, but you know, when my vision of that primary care doctor was who I grew up with, and you know, did everything for the entire family, from newborns to nursing homes and everything in between. And I think patients have really come to understand that, especially over the last couple of years. I think our organizations, you know, those represented here and others like us, have really been a great experimental ground for sharing best practices, and, you know, really elevating, you know, teaching people about telemedicine, telehealth. You know, that was something that didn't was a concept a couple of years ago, and, you know, we all basically had a baptism by fire and had to figure out how to provide care, whether it be at the curbside. You know, gives curbside consult a whole new meaning when during those visits. But I think we were able to share those experiences and share those best practices, and really elevate that coordination across the board for our patients, and that really is key. You know, as Dr. Pena said, so much can be managed in primary care, and I think maybe I'd like to see the pendulum swing back to primary care focused delivery, and not be so siloed in that specialist realm.
Yeah, I couldn't agree with you more. I think my whole career has been on the healthcare benefit side of the house, and just, one of the things that was a common theme was how slow it was for the healthcare industry to respond to change. All these other industries were experiencing great booms and great innovation and great changes. And, just telecommunications is one example, but healthcare wasn't. And in the last 2 years, I think we've seen such an explosion that healthcare can change and can change quickly. We no longer have to say it's going to take 5 years, it's going to take 10 years, because we have evidence that says that it can take sooner. And I think at the center of that is primary care and how they're going to drive that care. And the other thing I'll add is, traditionally we've thought as primary care as a gatekeeper. I think we've got some work to do to change the perception in the market that primary care is not the gatekeeper, but they're your champion, they're your quarterback, they're your coordinator, they're the leader of your care team that's going to help you navigate the system. So, I really appreciate all of your comments on that. I'm going to pivot a little bit to, how we use technology in primary care and how that actually has been reshaping primary care and has the potential to do even more. I think one of you mentioned that some of the systems or the data that you rely on is often old or lagged if it's claims dependent, and that you've been investing in other technologies. Can each one of you take a little bit of time to talk about what investments you're making in technology and where you see the most value coming in those investments, what you're trying to accomplish with it? Dr. Mullins, I'm going to pick on you to start, but please jump in.
Sure. Practice interfaces, especially for a company where we don't require anybody to practice with a particular EHR, has really led to some innovations in as far as efficiencies across different EHRs. And so that interoperability we'll call it, it has been certainly something that we'll focus on. Each state has its own version of the health information network with its varying degrees of sophistication. And when you can interface with a hospital, when you can interface with a health information network that's statewide, you can often beat on speed what claims-based processing can provide for you. And I think that that's a real effort as far as trying to get point of care data to be faster and more efficient. By the time something has hit a pharmacy claim, there's often a delay for quality that is beyond what we can interface at the point of care. So looking at ways that the information can reach the patient encounter faster are always going to be a great effort and a great investment as far as getting things to be better for a physician to buy in or for a practice to be able to act on something, because if it's not quick, it's certainly stale and not as actionable.
Dr. Mullins, are you using technology to also triage and sort of direct people, or are your practices still somewhat focused on some type of visit encounter to solve patient issues?
Sure. So our population-based software is not integrated in any particular electronic health record, but it does provide the information for who needs population-based outreach for preventative care services, for transition of care services from the emergency room, from the hospital, what the patient's clinical quality is needed. And this is something that's accessible as a window on any person's laptop at the point of care, or for a team-based member within the practice to be making outreach calls.
Yeah.
So we use it in both ways, and I think that's a really useful way to do it, is that we have it at your fingertips at the point of care, but also to help me think of the people who are not in front of me.
Very good. Dr. Pena?
Yeah, in our area, we have been named before as a high-touch, low-tech, because many of our patients don't have a smartphone for applications about, diet and weight loss and that kind of thing, right, at the patient level. In our side, as a physician, yes, we do have electronic medical record. So we have to, as I mentioned before, we create our smarter tech guys create a population management software that is able to digest all the claims-based information from CMS and transfer that to data that we can use to identify our high-risk, high-cost patient. Also, they are able to interface with the EMR to grab the quality metrics. But I think that I am a critic of the traditional electronic EMRs because they many times is like an electronic progress note. They should be able to do more aggregation of data. If we ask patients from this range of age on this insurance, what has been done, what gaps are, they should be able to provide, but most of them do not. So I think that the country as a whole, we can do a lot better on this also interoperability. And we think from CMS also, they should be able to provide more digest data rather than the raw data that we get from them. Also, our system helps us to do some risk stratification and a little bit of the holy grail, the predictive analytic, to try to identify who are those patients that are higher risk to be admitted before happening. So we do a combination of a lot of hands-on work with the technology combined.
Would you say, Dr. Pena, that technology is critical to be successful in value-based care? How you use it, how you get data, how you sort of digest it and expose the care providers the critical information they need at that point of care?
I would say that is very important. Maybe probably not necessarily critical. Maybe I am giving extra credit to the PCPs, but I think that you can be successful in a low technology environment with a very, very intense care coordination programs, as I mentioned before. But of course, the technology do help on the, again, identify those patients, high cost patients, and who is missing what, the gaps on care. You know, with a manual record, you cannot do that. So yes, it's very important.
Got it. And Dr. Walsh, I'm picking on you to go last, and I'll try and change up the order a little bit to give you a chance to go first, but would love to get your thoughts on this.
Sure, I won't just say ditto, but I think the technology is critical, kind of front to back, and I certainly don't discount the comments of Dr. Pena, and you know, as a family practice physician, I certainly agree with that low tech, high touch model. But I think, you know, one of the things that we're creating is really that patient identification and that risk stratification, and really working towards that. You know, not to manage your schedule or micromanage things, but to really make sure that those patients that wake you up in the middle of the night and you think, what happened to Dr. or to Mrs. Smith, you know, that we've identified those patients and we have that robust care coordination that's engaged those patients, but we have to identify who they are and, you know, their needs and what can we link them to in the communities, what resources are available. So it's taking not only the EMR data and claims data, but matching that up with our community data. It's matching it up with you know, the various points of data that we can get our hands on. And then I think technology is also something that can be you know, patient facing as well, be that your patient portals in your EMRs or working through text messaging and outreach. Not everyone has smartphones or email, and not everyone is tech savvy, especially, you know, we're dealing in a lot of rural areas and with an older population. But at the same time, there's a lot of caregivers who are out there who really like that extra touch or just a text once a week. How's your breathing doing? Have you gained weight? What's your blood pressure doing? Just those periodic touch points that we have found to be very successful, not only in managing a particular disease state, but across the board, just keeping those patients connected. And I think that technology, if we can figure out a way to identify those patients and do some of that outreach, that's going to be successful going forward. Not only on the back end and crunching data, but on that patient-facing front as well.
And sticking with you, Dr. Walsh, you get a chance to answer a question first. There was mention about, I think Dr. Pena mentioned about the bringing in a social worker and access to mental health, and we know that that's a big driver of just basic care in general, and the need for supporting our primary care providers with expertise in mental health and actually having quick access for patients. So my question is twofold. What are you doing on trying to embed mental health providers? And do you feel that there's value in that into the primary care practices? And the second part of that question is, do you feel that we might be asking or expecting too much from primary care?
Wow, great questions. Take the first one first, and trying to embed any service. I won't restrict it to behavioral health, but any service within primary care, I think is a great thing. Anything that we can do to take the burden off of the physicians and providers on the front line, and share some of that responsibility, whether it just be team-based care within your own practice or a collaborative care model with behavioral health. I think those are important pieces, and there's such variability across the country with access to specialty care, to behavioral health, that I think that is something that certainly is at the forefront of what we're all trying to do, and you don't want to wait 2 months to be able to see somebody when you're in crisis. You need that access quickly. And to kind of follow up on your second question there, are we expecting too much of primary care? I think we do, but at the same time, that's what we're trying to do is build that support network for them, so that we're removing some of that burden, spreading that out, but still allowing primary care to quarterback. I think you used that term initially, but to quarterback the whole care team, and to help manage that entire patient. You're not just focused on the blood pressure or the diabetes. You're looking at that entire patient, and that's what we preach. Is on a day-to-day basis. You're looking at the entire patient, and you're in the best position to do that. So any support that we can do with those with behavioral health, especially, because I do think that's an area where maybe we're in primary care overburdened, and really don't maybe have that support. So as we build out these processes, I think we're taking that burden off, but still keeping that patient focus there within the primary care office.
I think it's a really critical observation. I mean, patients are coming in for their primary care. That's an obvious touch point, and if it becomes clear that they're in need of some type of additional support, to ask them to go call 4 or 5 other phone numbers and wait for months to get care, I think you've sort of missed the opportunity to try and close some care gaps, some critical care gaps there. So appreciate that perspective. Dr. Mullins, would welcome your perspective on the role that mental health plays in your primary care solution and practices.
Yeah, the very high cost of untreated mental health is evident throughout primary care. in the diabetes data, in the hospital readmission data, in the ER utilization data, understanding the confounding and compounding effect of mental health is really extraordinary. There is a really tough problem with workforce in the sense that we don't have a lot of pipeline coming in the licensed clinical social workers, in the licensed counselors, psychologists, and the psychiatrists in this country, and solutions for e-consult platforms or consulting virtually. It has been brought up multiple times in pilot forms as a way to try to figure out how to extend the reach into underserved areas of the country. And for behavioral health, for mental health services, underserved parts of the country are basically everywhere. We're not talking about traditionally underserved medical communities, but simply entire states or swaths of the country where even primary care services are available without that type of mental health specific benefits. Some of the screenings and some of the investments that we're seeing in our contracts being emphasized are social determinants of health screenings, so that if we can meet a lot of social needs, some of the mental health or behavioral health issues are less severe. Not to say that anxiety and depression are completely handled by social determinants being met, but they certainly aren't any better when social determinants are confounding. So I think that there aren't easy answers when there's a workforce shortage the way we have it. But at the same, and to answer the second part of your question, yes, there is a lot being put on the primary care workforce right now, experiencing their own shortage, their own kind of underserved and their own mass retirement without a lot of help coming on the way. So whenever I think of something that can be resourced from an external source, so having something coming from the ACO in the way to help this type of primary care that's working on their own without a lot of support, I think that's absolutely our duty to do that.
Do you do PHQ-9 or PHQ-2 screenings when your patients come in?
So the annual wellness visits have absolutely a PHQ-2 or 9 requirement is part of it, and that being one of the tenets of what we do, really the focus is for virtually every patient to have that type of care delivery every year.
Got it. Dr. Pena?
Yeah.
I know you are doing stuff when it comes to mental health. Yeah.
Yeah, as discussed, I mean, the mental health issue, the admission per 1,000, when you decrease or take out the patients with mental health, almost come down to half, as Dr. Mullins said, is implicated in the cost, and then the access to mental health professional is short. So in our ACO, we are giving like grants to some of the largest practice to hire a therapist or clinical social worker, and at least 2 large practices already have those professionals, and they is the so-called integrated behavioral health, where they can see the patient on the fly, doesn't need to wait for an appointment, but after the PCP can do a hands-on, introduce the therapist and take it from there. And as it was mentioned, you know, non-compliance patient on morbid obesity, and many problems that we think is only medical, but have a component of behavioral. And of course, the dual professional that this therapist and social worker can address, you know, housing security, food insecurity, and many stress, you know, stress that is generated by lack of resources, particularly in our county that is one of the poorest in the nation. So mental health need is big. Is costly on front, but you know we get it's good for the patients, and we get compensated on the back end. Of course, we don't have enough mental health professionals available to hide it, but we are trying, and we're making some progress on that direction.
Thank you. Dr. Pena, I'm going to stick with you for a minute and ask a follow-up, kind of a magic wand kind of a question. When you think of all the barriers still in front of you, all the challenges to make these things work, you know, balancing that again with your successes as well, what is the one change you hope to see happen in the next year? I'm not even talking 5 years or 10 years, but if you could wave a magic wand and fix one problem, what would it be? Am I putting you on the spot? I couldn't answer. I will confess that I cannot answer that question because I have more than one, but I'm going to put you on the spot.
Well, I'm going to give you two answers. One is not popular, and it's called capitation. It's not popular on the PCPs because most of the PCPs are not familiar with the benefit of it. Most of our PCP are afraid of it, but I think global payment, again, when you can do resources allocation, that is going to be a benefit, but it's going to take time because we as a humans, we are afraid of the unknown. So that's why.
Number two, that might be, yeah.
Yeah, and the other end is technology to get cheaper. You know, this predictive analytics tool, they don't have to be, they should not be so expensive that many times we cannot reach that. So I guess you too, sorry.
I'm in your camp, Dr. Pena. Dr. Wallisch?
I figured you'd call on me next, but I mean that's a tough one, and you're not even granting us 3 wishes like the.
I'm not. I'm sorry.
but I would have to agree on the capitation front. I think it's just continuing to move towards that, but also Dr. Mullins brought this up. It's the shortage, and we need to address the shortages of the workforce. I think that's been highlighted in the last couple of years. So, I think the primary care base and the nursing base and just healthcare in general, we're lacking those folks. So that would really be the big thing to me is how do we develop that bench and those reserves to keep our physicians and providers fresh.
Not burned out. Yes, exactly. Dr. Mullins, you're up.
Sure. So I totally agree with the previous 2 answers. I mean, obviously, workforce is a huge issue. If there's no one here to deliver primary care services, it doesn't really matter what we want for them. And I do think payment reform is important. So I'll combine those 2, and I'll say that I've been part of the advocacy efforts in my state to pass a primary care reform payment, similar to Rhode Island and Oregon. And increasing primary care total cost percentage, I think, is an answer for both problems. So I do think it both helps with the workforce shortage, and it also provides that prospective payment. So if you want to avoid the word capitation, we'll just say prospective payments for investment in primary care in order to make sure that there are people here to deliver that.
Yeah, it's kind of like the chicken or the egg. And, we've built our system around fee-for-service, which is, I think, probably the primary cause for the mess we find ourselves in today. And to me, that's one of the biggest barriers to sort of really, turning and pivoting and putting our investment in primary care, boosting it up. How do you get practice that you cannot ask a practice to say, for these patients, it's capitated. For these patients, it's fee-for-service. We have to get the whole market to shift and go in that direction. I could sit on this line and talk to all of you for hours and hours, maybe even days, and still not run out of things to talk about and come up with ideas on how we can shake up the industry. But I want to make sure that we've got enough time for our audience to ask any questions. I don't know if any questions came in, but certainly want to make that available. And I don't know how to access the question and answer, so I think I've got some stuff coming in now. So this is a question for Dr. Wallisch. What are the negative impacts of ER utilization that you are seeing in your practice, and how can technology be used in preventing ER visits?
I think the biggest problem with ED visits is just the disjointed aspect of care. It's not a coordinated effort. It's even within the same EMR, sometimes it's not a a coordinated piece. So I think the biggest thing is that I don't want to say it undermines that relationship, but it doesn't highlight that relationship that we talked about earlier between the patients and their primary care providers. And I think, you know, I'm not sure that we necessarily need a lot of technology to fix that. I think it's you know, some access issues, and it's you know, being able to create space in our schedules, which is tough to do. We're talking about shortages, but being able to really have some processes in place to identify those patients, to get them in, you know, same day or next day, and you know, educate our patients about what really is the benefit of getting that coordinated care through the office rather than an emergency department. So kind of a low-tech solution, but again, it requires some effort and you know, process revision to make it happen.
And Dr. Pena, I think I saw on one of your slides, yes, a call first program. I think,
Yes.
Did you want to add to that?
Yeah, remember this 1 hour talk, that one. Let me try in 1 minute. We had several steps. One in every room of every, you know, where the patient go, we had the call us first with the phone number 24/7. We have a second phone in every office. On daytime, the care coordinator had that phone. In the evening, one of the providers had the phones. And we promote that practice. It's just basic CCN, right? The case management that Medicare started to cover that like 3 or 4 years ago, but we were doing that from inception. Number two, evening clinics. We try to promote, we have several practice, extended hour until 9 p.m., Saturday morning, Saturday and Sunday evening. Also, finally, we have getting data from the emergency room, partially, again, health information exchange called Experience. Let us know every day, at least on 3 of the local hospitals who was there. Secondly, we are adding, again, more nurse practitioners doing home visit. And we have a transition of care coordinator for people that go to the hospital or go to the ER, I mean, discharge and hospital visit, triage, when they can come or when do we go to see them. So we do promote and we do a lot of home visit. In 48 hours, everybody needs a phone call or a face-to-face, not to wait 1 week, 2 weeks, 72 hours encounter to decrease the chances to go back to the ER or to go back to the hospital. So there is a lot of things happening around that.
And I think it does tie back to trust. And where we started in the conversation was, you know, the primary care is your trusted relationship and building that relationship. And if patients can count on not just that they can trust the guidance they'll get from their provider, but they can connect with that provider when the emergency arises, because we all know emergencies or issues never happen during business hours. It's not a rule of thumb. That's another key component, that they can trust that they can get an answer from their care team within a reasonable time frame. I have one more question. I think we just have a few more minutes, but I'm going to try and get it in. And Dr. Mullins, I'm going to start with you. And that is your thoughts on the Medicare REACH program. That's a question that came in.
Sure. So formerly called direct contracting, this is the renamed direct contracting entity. So the ACO REACH is something that is another kind of iteration of looking at a way to use advanced payment reform. And the exciting things about ACO REACH are that they're starting to have a nod towards health equity, which is something that we're seeing coming as signals from CMS currently, is that health equity is starting to be prioritized. I think every time something like direct contracting or called ACO REACH starts to come out, people wonder about, well, what's going to happen to Medicare Shared Savings Program? And this is kind of where I keep coming back to, was that the Medicare Shared Savings Program has weathered multiple administrations in the federal government. It has support from both houses of Congress, and it is working. Although the health equity part of it is exciting, I feel very confident being part of a program where it's not likely to have ins and outs based on the administrations in Washington. My practice has been around for 34 years and it has to weather a bunch more still. So I think it's exciting to see these changes, but I think I want to stay with the ones that are actually the established.
Excellent. Dr. Pena, Dr. Walsh, any additional comments on it?
Dr. Wallisch, want to go first?
Sure. I think it's another iteration, and it's another way that we're all going to learn and collaborate and figure out the kind of the next step of some of those best practices. And I think it's another step towards that total cost of care or capitation model, if you will, that we mentioned before. It's moving towards that, and it's allowing, I think, organizations to figure out some of those payment pieces that maybe have been reserved in the TPAs and with the payers to this point. So it'll be interesting to see how that works out.
Right.
Dr. Pena, the last word.
Yes, I mean, in RDB ACOs is embracing ACO Reach, and we're ready for it. Again, especially because we work in an underserved community, and we think the program is tailored more so to serve those that need it the most. And it's just going to help us. I mean, it decrease and eliminate many of the quality metrics. We are already doing good on diabetes and everything else. Now it's focused on admission, readmission, and the customer experience, right? To keep the patient healthy at home. And we see as a positive evolution. Again, we don't know the future with all the politics in Washington, but I think it's at least as good for the underserved area. Have a very good plan of payment differential for dual eligible patients and so on that we're planning to take advantage of and to invest more on our social worker team to make it stronger and hire community organizers, not organizers, community workers.
Community workers, yeah. Well, but I appreciate the spirit, yeah.
Right.
Well, I can't thank you enough. I think we need a part 2 because you should see the list of questions I've got based on what you guys are doing, and certainly my passion for moving us away from fee-for-service when it comes to primary care, and really purchasers coming together and convening to try and push collectively push for this kind of change. So I can't thank you enough. All of you, you've been just so insightful to share your experiences and your thoughts. I'm looking forward to future conversations, and I'm in awe of the good that you're trying to do and put out for our communities on behalf of all of our members. So thank you again to all of you. Hope you have a good holiday weekend coming up, and look forward to continuing the conversation and our paths crossing again. Thank you to the Primary Care Collaborative for pulling us together.
Thank you.
Thank you.
Thank you for the invitation. Thank you all.
Bye.